Yeah.
over. We don't have enough time to discuss.
Okay.
So the last lecture, I would like to invite Dr. Phang Anh Khoa talk about the catastrophic failure of stent balloons, deflation, arrest, PCI complication. Please, Dr. Khoa.
Ladies and gentlemen, it's an honor for me to stand here to share with you an interesting case. From the beginning, we can see so many beautiful slides of complication. My slides is according to another option is catastrophic failure of stent balloon deflation. I think it's not a rare PCI complication, especially is newbie with me. I do not have any financial relationship. This is my some information case report, but I want to, because the problem of time, I just want to focus on the technical issues. So this is the 78 years old with a stable angina, with the ejection fraction is around 55%, and the angiogram will have tight lesions. The middle of the LCA is quite a like CCO in the RCA. This is a coronary angiography. You can see that quite a mediate stenosis of the LAD, and I have a stenosis, tight stenosis of LCX. Is here, and we have a total occlusion with a self-collateral channel from the ostium. And then it's easy, I think it's an easy case, so I use with a MLAT wire 6 branch and the filter XT wire, and it's easy to go through the lesions. And I think it's just, at that time it's finished. This is case quite done immediately. Just balloon and put the stent in. And I have a good lesion preparation with 2.0 and C 2.5, 2.75. And this is the angiography after we have a good lesion preparation. You can see it's quite good, right? So I choose a long stent around 46 millimeter across to the PDA, and we inflate it. Here the stent after the inflation. Around 20 seconds I put it in, but after that I cannot, because the negative pressures, after we have negative pressures, but the balloon of the stent cannot deflate it. At that time it's quite unconfident and quite embarrassed. So the first move of mine is quite, I remove the wire, the second wire, the PDA out. And then at that time do not know the correct thing to do. So I have to stop, and I have to go out, and because the patient at that time is quite consciousness and don't have any the chest pain immediately. So I checked everything again, and I see that we have to do in this another way. So I see that this is the failure of the stent balloon deflation. Although the inflation device achieved negative pressures, but the stent balloon kept expanding and did not deflate. And at that time, the patients become complain of general sweating, chest pain, but the blood pressure is still okay. So because we a little bit scared, so we contact with the surgeon, cataract surgery, active by standby at that time, just in case. So we do the step by step. The step 1, try to change the inflation device. Step 2, infuse saline into the balloon, and move on to the step 3. Step 3, step 4, and step 5. The first one, we change another inflator, but it didn't work. So at that time, this is not because of the inflator. Step 1, still I infuse saline, but the saline could not go into the balloon, could not go into the central lumen of the shaft of the balloon. So I did so many times, but it didn't work. So use step 3, rupture the balloon by inflation beyond burst pressure. I tried to go up, but at that time, even the number of the pressure is going up, but the balloon didn't happen anything.
So how high did you go with the pressure?
The pressure is 30. I go to 28, 30, but it didn't. Yeah.
Oh.
I think it's the pressure cannot go
into the balloon, for sure. Yeah. Okay.
And then I tried to cut the rail and use the guide liner and tried to use the back end of the wire to puncture the balloon. You can see that this is the ambulance wire, and use the guide pliers, go into the middle. And at that time, I tried to pull back the balloon of the stent to close
because your balloon slipped more proximal, yeah?
Yes.
Did you try the 5? This looks like a 6 French guide liner, yeah?
Yeah, 6 French.
Do you have the 5? Maybe the 5 would be...
No, I don't have it. I don't have a guide plus a small size, 1.3D, 33 millimeter. Yeah.
Okay.
So, but at that time, the back end of the wire cannot punch the balloon, even though it have a very close distance. And the patient still chest bend. I change another option. I use ping pong technique. I use another wire, go into at the proximal of the balloon, and use the back end of the wire, go into the microcatheter, and do the punch of the balloon. But it still didn't work. Even though I do the puncher so many times, this slide take a lot of times, around 30 to 1 hour.
Oh my God! Probably is because the wire is probably out of the lumina. It's not hitting the balloon.
Yeah, I think so. Yeah,
probably. Yeah.
Yeah, probably. You can see this is the back end of the wire, and like you said,
it's outside.
It's the outer vessel. Now, even though I do very strong, but the balloon didn't change anything. And I have to give up and call to the surgeon. To have a surgical remove, and I have to be there and discuss with the surgeon what is going on, where is the balloon here, and my option is how to pull the balloon out. So this is the result of the stent and the balloon. The balloon will trap on of the stent, and you can see this, when the surgeon pulls the balloon out, the stent will go within the balloon. And with the small of the atherosclerotic plaque up of the picture, yes. And this is the hemodynamic, the blood pressure after we finish the operation. And how did the surgeon get the balloon out? And they open a small hole in the middle of the RCA, and they pull the stent out in this segment, and they cut the shaft, and we put on the shaft from the beginning because we scared about the thrombus formation in the middle of the RCA. And after that, they have a bypass from LCX and RCA and PDA and PLV. And the patient was followed up around 10 days after surgery and discharge. And after 6 months, is still stable until now. And when we find some mechanisms of the failure of the stent balloon deflation, maybe it's from the mechanical obstruction, manufacturing defects, maybe create a new the one-way valve, or maybe the kinking blockage with the material like the thrombus or plaques or debris with our hands stick on the glove, or maybe it's from the force from operators. A forceful transaction withdrawal can cause the shock because when we use a OPN or we use a I think it's the scoring balloon, for example. Sometimes we can face with the balloon deflation because of the shaft of the collapse or kink, leading to obstruction. And one more, I think this is one force I think is coming from our case because during the contracts dilation step, the assistant surgeon may be careless and use undilated contrast, a very dense contrast for stent balloon inflation instead of properly dealing to it. So this is some mechanism, and my final slide is failure of stent balloon deflation is very rare complication. The preparation of the contrast mixture from coronary stent balloon inflation also require careful attention, even though it's a very basic step, especially in scenarios such as selecting a long stent. So after this case, even though when I use a long stent, instead of dilution with the one contracts, I go up to selling. Activating by standard catastrophic surgeries is something should always be considered from the very beginning, starting at step 1 rather than being carried out only at step 5. Thank you very much for your attention.
I think we need to congratulate you. It was a very nice case to finish this session. You are basically unlucky because it's very distal. If it's a proximal thing, it's much easier. What we used, and it worked really well, is use a 5 French guide extension, put it up to the balloon, and then use the Astato wire. The Astato wire always, you probably agree with me, the 20 gram is enough. Just puncture it. It's really phenomenal. And the alternative is to take the heart trail 5, but once again, only proximal. Cut the heart trail that you have the metal braiding of the heart trail, which is from Terimo, and you push it to the balloon. That also works. But in your case, it's too distal, You did everything you could, Thank you very much.
Thank you very much.
Thank you very much.
I think because even though it's stuck with the distal, but it is very difficult to approach with the distal.
That's the problem. That's the problem.
Some case stuck in the proximal, it's easier to approach.
And also it's a long balloon, makes it also much more complicated. Okay.
Thank you.
Very well. Sorry, dear panelists and dear chairs and people in the room, we are terribly behind time, 24 minutes. Sorry for that, but it's interesting. Thank you all for being here and for your discussion points. We go to the next session with some delay. Thank you.